Good evening, friends. Welcome to this Tuesday evening meetings, which has been a constant phenomenon for the last 3 years or so. And Happy New Year to all of you. We wish a very healthy and happy and prosperous New Year's to come, filled with a lot of education, learning, and academics without much of health issues or pandemics to us. And
Floods.
and floods, yes, natural calamities altogether. And We wanted to start the year with a kind of a new beginning, and we found none other than our Ram sir, who has been a favorite for many of us from our student days. And we wanted to bring some topic which is of interest to all of us above the regular standard of care. And we thought one of the topic which he has been delivering recently is the phenotypes in both sepsis and ARDS. We all know that not one size fits all, and we know each patient is different, and they have their idiosyncratic way they behave to many treatments and modalities. So today we want our Ramsar to take us through both the phenotypes in ARDS and sepsis and its in future implications, whether we have any clinical implication role in future coming. He heads the Department of Critical Care Medicine in SRMC, Sri Ramchandra Medical College in Chennai. And he happens to be a seasoned speaker and a teacher for all of us. And we look forward for your learning experiences with us, sir. So welcome you on board. And it's an honor to always have you on board, sir. Over to you, sir.
Thank you, Venkat. Again, I apologize for the fact that I cancelled many times. One was genuinely a natural calamity, and the other one was a expression of my cynicism. Supposed to do the next one. So I apologize for the fact that I've been postponing this, and I wish you all certainly a happy new year. The topic that I'm going to be picking is going to be a little unusual. I mean, all of you have heard about the idea related to phenotypes and subphenotypes, but I think very few of us honestly understand the principles behind phenotyping adequately. And I hope that I will be able to introduce those concepts to you in a reasonable way. Okay. So with that as the background, as I say, it's a layman's guide, and I'm not assuming that you're layman. I'm assuming that I am a layman going to be talking about subphenotypes in critical care. And there is a concept that we need to understand, an analytical concept called cluster analysis, that is absolutely central to understanding what these phenotypes are. So as a consequence, it may be a little bit on the odd side. Okay. All right. So when I start with all of this, basically people ask me to read the literature. The first thing that turned me off is the fact that something about artificial intelligence was introduced into that. And I had this standard joke of natural stupidity, which I've censored right now, because I noticed that this joke is being repeated by virtually everybody I know related to their ignorance about artificial intelligence. Anyway, the thing is, I think that is a little too naive of us to get worried by the issue related to artificial intelligence, because that's only a process that is required for the analysis of phenotypes. And I don't think we need to know the ideas behind AI for us to be comfortable with understanding phenotypes. So with this in the background, I think all of us understand something has happened. Okay, over the years, our mortality in sepsis has definitely declined. I don't care how you achieve this definition, but it has been a modest decline over the last probably 15 years or so. But what you do realize is that despite that decline, may be related to the way in which we provide current critical care, appropriate antibiotic cover, and source control, the majority of patients still die. Not a majority, certainly a very large minority of patients, about 40 odd percent will still die related to sepsis. Okay, and this is something that we need to be very, very clear, is that we are not doing everything that we can to reduce the mortality in sepsis. Likewise, if you look at ARDS also, the maximum change that we had is probably in the late 1980s, when we learned how to ventilate these patients a little bit better. And all the injury that we are creating to these patients with ARDS is probably what reduced the mortality, and not anything specifically against, treatment for ARDS, because that has remained very stable. If you look at the last, this is a little truncated, but I think this has been effectively the kind of outcomes that we've been seeing. We are averaging around 40% mortality in patients with ARDS. So both of these conditions leave us a little concerned, and they are definitely the crux of all that we do in the ICU. And the reason for this probably is something that we shouldn't blame, okay, Osler for all of this. Osler definitely added a lot to our understanding of, understanding and practice of modern medicine. But what he promoted was what you would consider a kind of a holistic approach, where he basically tried to derive everything in terms of syndromic patterns. And the big advantage of these kinds of syndromic patterns is the fact that it minimizes the number of processes that we need to consider. So from a point of view of a dumb human mind, this becomes quite easy for us to analyze the differences between the different syndromes. But at the same time, it has a tendency to overgeneralize. Okay, it does not give you any kind of room to consider individual susceptibility to disease, nor does it take into account any kind of prior background that the patient may have that will alter his response to disease. So if you really look at the idea of both sepsis and ARDS, we are effectively trying to do what Osler was recommending, which is to lump everything into syndromic patterns. We lump anything with a hypoxia and an acute lung disease into ARDS very routinely. And we lump everything with an inflammatory response to infections as sepsis. And this very clearly is a dramatic oversimplification of the process. So when you look at all our data and clinical trials, for instance, trials that have shown dramatic value in one group of patients, like for instance, the EGDT, which came out in 2001, everybody was raving about it. And everybody felt that we had a great solution. You put in a mixed venous saturation, and ultimately all your patients will survive the acute septic kind of a process. But we recognize that when it was studied actually in other subsets of patients, it was not at all replicable. There was clearly a strong component of heterogeneity that resulted in positive results in one group of patients and negative results in a large number of other groups. Likewise, if you look at what happens with the ARDS and say the application of PEEP, while PEEP is very physiologically an appropriate kind of a process, which should improve your oxygenation very dramatically, and it does in all these clinical trials, where you see a dramatic improvement in the levels of oxygenation when you apply PEEP, but it doesn't seem to translate into survival benefits, primarily because our definition of ARDS has been a very heterogeneous kind of a population is being included in that. Some are recruitable, some are not recruitable, and the effect of PEEP is going to depend on the proportions of these patients that we will ultimately have. So what we are recognizing is the heterogeneity of patients and their response to treatment clearly limits its efficacy. Okay, the therapeutic success that you will see in one population, like in the EGDT trials, doesn't work in other groups in the EGDT trials. Likewise, there is a very certain concern about the inefficacy of a wider treatment, even though it may have a strong physiological rationale. So what becomes very obvious is, as much as Osler's ideas about syndromes are probably quite relevant to some extent, it is probably too much of what we would call a lumping of the process. And all of us have recognized this. I think we have all clearly understood, oh, why does it not work in ARDS? Primarily because our definitions are a little too loose. Okay, so with that as the basic understanding, we have gone through a process of trying to subgroup these patients. One of the rather naive attempts in the initial phases of, say, dividing sepsis is this idea of the PIRO kind of a methodology, which again tries to identify the importance of not just looking at the septic patient, but also looking at, say, the predisposition to infection, which can be related to the age, gender, and prior, and prior comorbidity. And the other side of the equation is definitely the fact that the nature of the infection, the patient's response to all of that. Each one of these can definitely and strongly affect the outcome. Okay, so with this as a clear understanding, we were trying to figure out how we can try and subgroup our patients. And I'll just give you the traditional way in which we do the subgrouping. So effectively, we use what is called a variable centered analysis, in the sense that we look at parameters that are strongly associated with a specific response. It may be death, it may be weaning from a ventilator, it may be discharge from an ICU. But anyway, we try to look at the factors that are strongly correlated with each of these events. So, for instance, if age, oxygenation, and the SOFA score, for instance, are tightly correlated with your mortality, okay, we try to look at the associations over here, and then we recognize that this is not something that you can look in a univariate kind of a fashion. We try to do what are called multivariable associations. And in this, we basically identify factors that are independently responsible. So, for instance, see, the SOFA score may have an association, but it's probably because the SOFA score is linked to the level of oxygenation. So, when you look at them independently, the SOFA score doesn't add to any information that the oxygenation parameter will not give us. So, this is the kind of approaches that we take, what we call as your multivariate regressions that we typically use. And once we identify these factors that are independently associated with a specific outcome, then we try to develop some kind of a risk stratification process. So if we realize that age is a very strong factor and oxygenation is a less strong factor, we give it a specific weightage. And basically, we multiply that by a specific weightage to derive what we may call a risk stratification, subgroup, a risk stratified or risk adjusted subgroup, where the age score and an oxygenation score is basically derived so that you can judge what is called the probability of a specific outcome. Here, the basic presumption is that if you can identify these kinds of risk adjusted subgroups, they will be groups that are physiologically linked to each other, and therefore should be a good way of trying to subdivide these patients instead of looking at them in a large heterogeneous kind of a group. So let me just take the classic example. So why am I a little concerned about this kind of a process? In this kind of a process, and typically we see this in ARDS, for instance, where we found that virtually nothing makes a differentiation between the subsets of ARDS patients other than the oxygen parameter. So the Berlin definition went very strongly and said, let's look at the PF ratio and then divide these patients into different subgroups because they are associated with different outcomes. Okay. And as a consequence, they may be the best way in which we can look at are specific responses to therapy. This may be a good way to look at it. But there is a serious problem. When I take something like a PF ratio, okay, yes, it may be by my multivariate analysis, it may be an independent predictor of survival. But the fact of the matter is, it is not a very discriminant kind of a parameter. A worsening oxygenation can be from 100 different causes. Like we saw in COVID, the vascular disease that underlies it is just as important as the extent of the lung disease. You can have VQ matches, you can have problems related to that, you can have ventilatory modes that can be very different. Each one of them can strongly affect the oxygenation, and to use it as a predictor of the severity or of the subgroup of patients with a certain outcome is going to be extremely poor. And likewise, when you look at intergroup distinctions, it's very difficult. A PF ratio of 200. What if it is 201? What if it is 199? Are they clearly different from each other? Not necessarily. The cutoffs are at best very vague and probably crossing over. So likewise, when you look at other factors, most of these parameters that we look at as predictors of outcome are almost always markers of severity. The worsening of oxygenation is going to be associated with a poorer outcome. This doesn't require a genius to figure this out. Okay. And obviously, the more severely ill you are, the more likely you're going to have an adverse outcome. That doesn't necessarily make you into a different kind of a group. And it is extremely important to realize that something like oxygenation has a time dependent variability. So if I see oxygenation in somebody in the early part of their disease, I may lump them into one group on the PF ratios, while they may progress on to another group in the PF ratios. And this is going to be a serious problem. I'm not able to subdivide the patients into different functional groups on the basis of something like the oxygenation again. And as you clearly, because of this, over a period of time, patients can migrate from one group to another. And really, these kinds of ways of subdividing patients are at best rather arbitrary and rather reasonably naive. So we need to think about this in a completely different way. And I just want to summarize what we traditionally will do. So if I have a group of patients that are heterogeneous, marked by the differences in color in the beginning on the left side, okay, they can, I mean, over time with a specific disease, okay, have different levels of propensity. Let me just see if I can get my they can have different levels of propensity. So for instance, these patients probably don't get any kind of an inflammatory response when they have sepsis. Okay, there may be others who will have inflammatory responses, but these inflammatory responses get worse over time. And as a consequence, when I'm using many of my so-called variable centered analysis, I don't look at these patients early in their time. I look at them dominantly after they've developed all kinds of other changes, a higher cytokine level, a lower oxygenation, greater organ dysfunction. All these are an end point. And that is unfortunately what it will do is it will excellently predict. If I knew that a patient has bad organ dysfunction, very high cytokine levels, it's very likely there is going to be an associated mortality in that patient. But it's a marker of the severity and the progression to that degree of severity that we are seeing over here. It is not very clearly an identifier of which patient will go into which subgroup. So it is really very good in the sense that it will have excellent prediction. Okay, it assumes that the entire group is homogeneous, which is not at all very true. Okay, and it'll have very limited generalization. If I take a subgroup, it'll depend on the number of patients in each of these subgroups within a given population. And if I try to extrapolate it to a different study, I will not see that kind of a difference. We've seen that in the ARDS studies, we've seen it in the other studies also. And what is extremely important about these parameters is the fact that they are very clearly time and severity dependent. Both, remember, time and severity are closely linked to each other. The longer you wait, the more likely you have a severe illness. And time and severity dependence actually makes it very difficult for you to differentiate whether it is a true characteristic of the patient or the characteristic of his response to the disease. And as a consequence, we can't make such a strong kind of a differentiation. What we want is a completely different kind of a parameter. What we want is something that identifies the heterogeneity very early. It recognizes this maybe even before they develop a disease. It can identify an individual as somebody who may respond poorly or who will respond better. It may identify them in terms of the propensity of getting an infection or not. Okay, and it also probably will define them in terms of what the severity of their cytokine responses will be over a period of time. And here, what we are doing is we are attempting to identify these patients long before they develop these parameters of severe illness. And this is very important, that this kind of heterogeneity should be based on a baseline characteristic, okay, which should be clearly time invariant. So if I saw these patients even at a later stage, they can be defined by the same characteristics that they had initially. And that is going to be very, very important. And it also should be severity invariant. So I need to have a way in which I can identify all these patients at an early stage before they get severe illness. And this is going to be the most important thing that we have. Here, I will take you through a very important Indian biographical kind of an experience. Among the people who have been talking about this process, as you might realize, is not a variable-centered approach, but what we may consider as a people-centered approach, a definition of individual people and their responses. And one of the people who talked about this person-centered analysis is this man called Mahanoblis, okay, Mahalanobus. I find it tough to pronounce his Bengali name. I can say Prashanta Chandra very easily, but I can't say the last one. Okay, also known as the professor. He is very important for what he called the Mahalan, this distance basically, which is a parameter of relatedness. Okay, what I love about his entire history is he got admitted to the University of London, which we know is not necessarily something that you talk about. But apparently, on his way, he missed the train and stayed in Cambridge. And he just went to King's College and asked them for a position, and they gave it to him. Okay, so obviously, I think this is a little bit of a fake story, but probably he was somebody of a genius who is also responsible for setting up the Indian Statistical Institute, which if you talk to any Indian Nobelist, particularly the economics Nobelist, they all hold that institute in high regard. Anyway, just as a aside as far as this is concerned. So what did he do? So effectively, what he said was, when you are talking about patients like this or people like this, they are a heterogeneous group. Okay. And we have no way in identifying what subgroups of patients are absolutely present. Okay. And what we can say is there must be subgroups of individuals who are probably likely to have an identical biological behavior over a period of time. And how do we recognize these similarities? We basically look at all the variables that may be age, maybe gender, maybe region from where they come, whatever else may be the factors, and ultimately try to see if there are strong associations that identify what you may call the individual over here. Okay. And basically, that is what they do in cluster analysis. And I'll show you some examples of that that will make this a little bit more clear. So what cluster analysis does is it is an exploratory technique that identifies these hidden structures. We don't know what these hidden structures are, but we do find that there are individuals who have associations of a lot of parameters and look like they form one kind of a homogeneous group. And this is without any a priori knowledge of the number of hidden structures or the importance of these hidden structures. But ultimately, what he does is he identifies them in terms of their associations of these various variables. This can be done in varying methods and varying analytical methods. I'm not going to go through this in any detail, but just to give you an idea. So when we looked at variable centered analysis, if a patient had, say, different parameters, we will try to see what the association of this parameter is with an outcome. Okay. And then we will try to call it as a severity marker or a marker of a severely ill individual of some kind. And we'll subtype them on the basis of these parameters. What he does is completely different. He does not look at these variables as outcome predictors. On the other hand, he tries to look at these variables in terms of their association with other variables. And this is where the Mahanobalist distance becomes quite relevant. And what he looks at is the closeness of these association of these variables, identifies this as a single group, and the distance that these variables have from other variables identifies their distance away from other clusters. And you effectively can be defining your entire population in terms of multiple clusters of patients who have variables that are very similar to each other and which seem to be closely associated in most of these patient subgroups. Okay, and effectively, this is what they do, and this is the idea behind a cluster analysis. So if I was to extrapolate this a little bit more, okay, this is basically an identifier of an underlying subgroup. It is the marker of a person, so person-centered. It is not the marker of an outcome. It is not a variable-centered outcome. Okay, it is basically the marker of an individual. Okay, and that is what they're trying to identify. So, for instance, once I have a heterogeneous population where I can identify the variables, I can use artificial intelligence, I can use what are called unsupervised algorithms. You can do it in any different way in which you can do. But once I have identified them, I classify these into what you might call as a different class or a different person, if you want to call them that. Okay, so you may have three different kinds of clusters and three different kinds of persons. Okay, but it is very important that this homogeneous group was identified only retrospectively. We didn't know of its existence at that initial time. And then what we do ultimately is then look to see what these persons, also known as your subphenotypes, have in association with a specific outcome. They may or may not have a predictive value, okay? And that is very important for us to completely recognize. So what we are doing over here in terms of phenotyping is a completely different approach to looking at variables and their associations with one another to identify groups of individuals, also known as subphenotypes, okay, to see if these subphenotypes will respond very differently to different therapies. And that is what we are doing. In biology, typically, a phenotype may be defined as the expression of the intrinsic genotype with its interaction with the environment, what are called epigenetic factors that you may have. Okay. And this is the expression of the phenotype. It could be in various ways. It could be in terms of a blonde hair, a brunette hair, or a red hair. Okay. And it may or may not be associated with specific characteristics, though it's very common to talk about dumb blondes and volatile redheads. They need not be true associations, but basically we can identify redheads as being genetically very similar and responding to their environment with a specific phenotype. So effectively what we are doing is we are identifying the phenotypes, and that's all we do. We do not worry about whether these phenotypes or these persons have any functional or different implications at all. In medicine, on the other hand, the phenotypes have to have that. So we define a clinical subphenotypes as the existence of a lumping of a certain set of disease attributes, what you call as your class traits. Okay. And we describe the differences between these groups of individuals in terms of the cluster analysis that we talked about. Okay. And we expect that when we have these kinds of different groups, that they will have differences in their responses, either to to therapy or in terms of their progression to a adverse outcome, for instance. So there is an added expectation that these phenotypes or subgroups will also identify differences in the kind of responses that the individual will have. Okay, so typically, how is a phenotype different from your traditional subgroup? And this is something that we need to recognize. Number one, traditional subgroups, as we said, have no discrimination. There is far too much of an overlap with multiple kind of parameters. They are rather arbitrary in basically what we pick. And these will be non-arbitrary, multi-dimensional descriptive traits that identify a person and describe and clearly distinguish them from other persons. Okay. And this is completely distinct from the traditional predictors of outcome that we will typically look at. So number one, it has to be highly discriminate. Number two, the intergroup distinction should be strong and misclassification should not occur. We already talked about the PF ratio, for instance, and we talked about the fact that there can be large amounts of overlap of intermediate values. Here, we need to have groups that are distinctly different from each other, okay? And that is the second thing that we need to look at. The third thing, as I said, and this is something that people always have a debate, I'll talk about this temporal stability. As I said, if you identify somebody as having a specific phenotype, they should remain in that phenotype through their disease. A phenotype that changes with the disease is basically changing, is not a true phenotype. It is a description of the progression of the illness. And this is something that should be very clear. There has to be a time dependent stability, or in other words, if it doesn't change over time, it should not be a marker of the severity or the progression of the underlying illness. And that is going to be very relevant. And ultimately, as we said, we shouldn't migrate. You shouldn't have a PF ratio of low values in the beginning that progresses onto a very high value, I mean, or the other way around, uh, as the disease progresses. And that is not a very good parameter. So all these characteristics should be present in what we call as a subphenotype. Okay. And these subphenotype ideally should be derived not only from high quality databases, they should probably be prospectively validated, including in randomized controlled trials. Now, I have a small problem. I actually, before I gave you all this talk, I had gone to a bunch of mathematicians trying to see if we can talk across specialities. And while they were broadly appreciative of the way in which I was talking about these phenotypes, The one thing that they all had a very strong reaction to was my importance in terms of the temporal stability. Okay, the reason that I have a concern about the temporal stability is the fact that if your patient, say, if I was to look at, say, cytokine values and say cytokine values are changing over a period of time, a change in a period of time is usually a marker of severity. Or, in other words, you can't differentiate time and severity from each other. And as a consequence, a temporal change is more of a reflector of severity rather than a marker of the specific subphenotype that you're dealing with. But they argued it a little differently and said you have to look at these kinds of parameters in a different way, primarily because there may be individuals. Yes, my cytokine levels can change over time, but the trajectory of change can be very different between the subphenotypes that we are going to be looking at. And this actually brings in a little bit more of a complex kind of analysis, where we need to look at the subphenotyping in over time. What they use is what a group-based trajectory modeling, which becomes a little bit more complex. Don't worry about it. But the importance that I would raise is we can't just be very strict about the fact that, oh, if somebody's cytokine levels are changing, that we shouldn't be including them in the same phenotype. They can be included as long as we take it in terms of the trajectory of the changes. Okay, so I hope I can just pause over here for a minute and
Yes.
try to say what did I make any sense of what I was saying? Okay, so effectively, what I was saying is most of the disease condition, whether it is sepsis or whether it is ARDS, is characterized by a huge amount of heterogeneity. The way in which we have traditionally assessed this heterogeneity is basically look at the what are called your variable centered kind of analysis, where basically we look at variables that are strongly associated with bad outcome. We lump them all together, develop some kind of a model, and then say this is the definition of a person who's likely to progress to a bad kind of a state, in contrast to somebody who doesn't have these features. That, as I argued, is completely wrong, primarily because it is more an indicator of the severity of illness rather than the patient himself or the features of the patient himself. And we needed to define this completely differently. And here we have now realized that we can look at multiple variables that may have strong correlations with each other and may identify subgroups of patients, okay, even before they develop severe illness, and probably can make predictions about the way in which they will progress over a period of time. And this kind of knowledge is going to be something that is going to be very useful for us to make decisions in terms of which patient group requires which kind of therapy. So the so-called customization of therapy or targeted therapy that we're talking about is basically built on this kind of an ideal. So how do we do this? Okay, we basically define a problem, say it is sepsis and its outcome. We pick variables to evaluate. Here there can be a little bit of controversy. Okay, some of us will feel that we need to pick the variables that are associated with traditional parameters that we look at. But there are others who say that our knowledge is so incomplete that we may be missing a large number of variables which may have an association, but we don't look at it. And under those conditions, this is exactly where data mining and machine learning with an artificial intelligence kind of a program may be something that will contribute to the selection of variables a little bit better. And then after that, we decide on a cluster analysis kind of a method. Okay, as I said, it is not just one method that is available. There's a large number of options that are available. Some of them actually require large number crunching, which may require not only complex computing, but also some degree of artificial intelligence to make that kind of a analysis possible. And then ultimately, we decide on a certain number of phenotypes. Just remember, if I took an entire population, each one of us can be considered an individual. And theoretically, there can be as many phenotypes as there are individuals. But that is impractical. That makes it like a N of one kind of a study. You can't have any extrapolation. On the other hand, we try to derive a certain number of phenotypes, which we think is reasonably logical. And you can use statistical methods to judge when you are overdoing it or when you have not done an adequate number of phenotypes of your patient groups. I'm not going to discuss that either. But as I said, okay, the AI process in the selection of variables is something that we find it very difficult. Very typically, when we say, I want to look at a phenotype, as you said, we select all the clinical variables, lab and clinical parameters that we are happy with. But as I said, there can be multiple ways in which we can be confounded. And an AI method that looks at atypical test variables. This is what we call as unsupervised deep learning, if you want to have an idea of that, okay, becomes quite relevant. And we can also use this for data extraction from the medical record. Not all of our medical records are completely electronic, and there are several components of the medical record which are relevant, but which cannot be easily coded. And for here, the natural language processing that we have, which includes your chat GPT kind of ideas over here, okay, can make a very big difference in deriving a little bit more data from your medical charts. And this is the kind of components of AI that we need to be certainly concerned about. It quite irrelevant to us broadly, but it is reasonably logical. But what is very important is once I have these phenotypes that are derived, and as I said, the number of phenotypes I've derived are rather arbitrary. There can be some subjectivity, but effectively, I need to show these three factors. Number one, that they are severity invariant, that they are basically not a restatement of your old Apache score. Okay, your Apache score will show you increasing severity is associated with poorer outcome. But this shouldn't be a complex restatement of that entire idea. So you need to show that there is a complete independence from the standard severity scales that you have. The second thing, as I said, time invariance, but I add a little bit of a limitation in the sense that trajectories or changes of your cytokine values, for instance, may be valuable pieces of information. So we can't reject all time invariance, but broadly, we want characteristics that are reasonably stable over a period of time. And the last thing is it should be contextually different. So the nature of the infection or the site of the infection shouldn't influence the way in which we are going to be analyzing this data. So effectively, that's what we have. Now, let me just take a few studies that have looked at this kind of subphenotyping. And basically, one of the landmark articles that came out in 2014 is this Carolyn Caffey kind of study that is very important from being one of the initial trials that talked about ARDS subphenotypes. Okay, here, this is a retrospective analysis of a large database that is from the ARMA and the alveoli studies, where basically they looked at traditional clinical discriminant markers like heart rate, ventilation rate, minute volume, vasoactive use, etc., and also a bunch of biomarkers that they were linking with this. And they subject this to a process known as latent class analysis, which is a method of cluster analysis. And what they identified by the best fit was they identified two groups of patients. One they called as the hypoinflammatory, and the second that they called as the hyperinflammatory. You can't derive this by looking at one parameter, but you'll have to look at the entire set of parameters that you're going to be looking at to make the differentiation between the two. Okay, and here they tested it. They used one of the studies as a derivation cohort and the other study as a test cohort to validate whether these subphenotypes were of relevance. And here we have to remember that when they look at these parameters are sufficiently different from each other. Very typically, this is expressed in terms of what is called a standardized variable value, where the mean values are taken as 0 and the standard deviation is taken as 1, just to standardize them across scales. Different parameters are measured in different values. But basically what it shows you is in the hyperinflammatory versus the hypoinflammatory, a specific parameter like the interleukin is distinctly different between the two. Likewise, if you take the other end, bicarbonate and protein C are distinctly different in a different direction in the other two. So effectively, with the exception of a few parameters in between, which may not have too much of a discrimination between each other, when you take this entire subset, there is a clear difference between the parameters that you see as a description of this group versus a description of this group. And in that sense, this has got clear intergroup distinction with very low misclassification kind of rates. And this is the way in which we look at the phenotypic variables. The value of this also, as I said, is not knowing that there are two groups alone, but whether these two groups have a ability to make a distinction between those varying subgroups. One, in terms of, say, the probability of dying. So what you might call as a prognostic discrimination. If there's a phenotype A and a phenotype B, if the mortality in phenotype A is lower than the mortality in phenotype B, we would call that as a prognostic discrimination between the two distinction or discrimination that we have with these two parameters. You can also look at it in terms of the therapeutic response. So you can talk about what is called a predictive discrimination. So if a specific group responds to a therapy with a lower relative risk in contrast to a higher relative risk, that is a distinctly different group. And this is what we are trying to do by discriminating these varying phenotypes that we have. And just to look at the data, if you remember the original ARMA and alveoli study that looked at the use of, what do they use? First of all, they were unable to show that when we are using a high PEEP strategy effectively versus a low PEEP strategy, that there was no difference between the outcomes in both of the subgroups. Okay. So effectively what they showed was there was no big difference between the two. Okay. But when you divide these groups into this P1 and P2 kind of groups, both in the derivation cohort and in the test cohort, okay, forget about the frequency of this, okay, what you see is there is definitely a distinct difference. In the original studies, which included all patients with ARDS, there was no distinction in terms of mortality, okay, over a period of time. But here, there was definitely a very strong difference in terms of your mortality. Okay, and this was not just a predictive discrimination that you saw. You also saw that the responses to the application of high PEEP was very distinctly different. So, for instance, in patients who have the P2 or the hyper-inflammatory phenotype, the addition of high PEEP was of benefit. The mortality came down. In contrast with the hypo-inflammatory subset, where the application of a high PEEP actually increased the mortality, or in other words, it was harming these patients. You were able to make a distinction between these two groups, okay, on the basis of baseline parameters, which very clearly showed not only the prognostic difference, but also their therapeutic responses to specific treatments. And that is effectively what we wanted to see. What is very fascinating is when they looked at it in other subsets of patients that they had, they got data from the FACT trial. You remember FACT trial is related to fluid restriction in ARDS, which didn't show any kind of a benefit for the fluid restriction. Here, they saw if you look at subsets of patients based on the P1 and P2 kind of subsets, okay, subphenotypes, we very clearly see a difference. Here, fluid restriction harms the ones who have a hyperinflammatory kind of a pattern, but it seems to help the ones who have a hypoinflammatory kind of a pattern. You also see the responses to statins, which have been, something that has been touted as a therapy for ARDS, seems to be very differential in these two subsets that you see. Okay, so very clearly, what we saw is we can derive these phenotypic differences in these patient subgroups, which clearly show a difference in terms of their prognostication and in terms of their response to specific therapies, which was not seen when you took the entire group all together. Another important factor is, again, we talked about time invariance. What they basically said is, if I was to catch a patient sometime later in their disease, and if my phenotype changes over a period of time, it will be terrible because that is more of a marker of the progression or the severity of the disease. On the other hand, if my phenotype remains the same at the initial and on subsequent analysis, it would be very worthwhile. And that's basically what they saw. This phenotype 1 that was present, okay, on day 0 was present in 93% of the patients even on day 3. Or in other words, there's a reasonable temporal stability of the phenotypes, okay, over time, okay, both in the alveoli and in the ARMA study, okay, and of both the phenotypes. So 92%, 91% of the phenotype 2 remain phenotype 2 on day 3. Unfortunately, this is not a long enough period, but a strong suggestion that the phenotypes that have been derived are time invariant, which is a very strong component that I would argue is necessary. And the last component that we said is we have to say that these phenotypic differences are not necessarily a new restatement of what we traditionally will look as predictors of illness. So, for instance, we know that age is a predictor of illness, okay? But if you look at the phenotypic model, age is not a very strong factor. In fact, age falls over here, but there is no distinction between the two. So what you're seeing in this phenotypic model is distinctly different kind of parameters to the traditional parameters. And that is something that we need to be very clear about. Okay. All right. So that is the first thing that we need to understand. There is a definite temporal stability, and there is clearly an independence to the traditional markers of severity. So in that sense, if I was to look at this particular study and give it a score and say we are looking at 8 different parameters, we can look at it. Is it highly discriminant? The very nature of the analysis, the cluster analysis that we do, makes it highly discriminant. There's no question about it. Okay. Is it different from traditional predictors? They didn't compare it with Apache scores or anything like that, but they looked at certain parameters and said, yeah, maybe there is a difference between the traditional predictors and what we see as predictors in this model. Okay, when they make the comparisons in terms of the severity indicators, they didn't do it in this particular study. They didn't do an Apache score and then compare it. I'll show you that in sepsis a little later. Okay, time invariance and time stability seem to be there. Okay, minimal migration between the subgroups was probably not tested very carefully, but they did see over a period of time there is no change from one subgroup to another. Okay, is it derived from high quality databases? Yes. Is it prospectively validated? No. It has never been tested in a randomized controlled trial. So it has got a marginal performance. It's not exactly a best kind of score that you can have. Hey, quick question. How am I doing in terms of time? Am I over exceeding anything at all?
No, sir. No, it's a class. We have now it is 47 minutes. We have another 20 minutes.
Okay, no, I don't know because it may go a little longer than that. But
Okay.
anyway, I'm going to try and see if I'm being reasonably clear about it. Okay, so this was one method. But if you remember, what the parameters that we used for this particular kind of methodology was a wide range of parameters, not only including it was looking dominantly at your inflammatory and your broad clinical kind of parameters. Somebody suggested, can't we look at ARDS basically in terms of the way we traditionally will look at it? Okay, can we define them on terms of the respiratory mechanics alone into one group, into one phenotype or another? This is not a subgroup. Here again, you need to look at all these respiratory mechanics processes, do a formal cluster analysis using, in this particular situation, they use latent class analysis, and they identified two subgroups, two phenotypic groups, what is called the recruitable and the non-recruitable. And very clearly, as you notice over here, the recruitable subset is definitely associated with a poorer survival. There is definitely a prognostic discrimination that you have with the phenotyping. And again, as I will show you, the subsets are clearly different from one another in terms of the varying parameters, like I showed you in the previous graph. Then, if you look at their responses, it is also very interesting that when you define these two in terms of a phenotype 1 and a phenotype 2, which is a recruitable and a non-recruitable, there is a very big difference in the way in which the volume changes of the ventilated lung, or the recruitability occurs, the change in the dead space, and the change in the PF ratios. But this is not necessarily. This is a first step to saying that there are differential responses on the basis of the existence of different phenotypes. This again probably needs to be prospectively tested in a randomized controlled trial. Another very tempting kind of idea that we have had about phenotyping is the way when we were seeing COVID ARDS, we started using that word cards, for instance, COVID related ARDS, on a belief that it is a distinctly different kind of pathology. And the main reason that we always argued about that was, at least in the clinical trials that we saw, that there was a difference in the way in which the inflammatory responses of these lungs were different from what we traditionally believed was common in ARDS. We never thought ARDS will respond to either steroid therapy or to immunosuppressive therapy, which was clearly what what we saw in cards. So the big question is card basically a subphenotype of ARDS that is distinctly different? And here there has been at least one study that has looked at it, which says no, cards is like other ARDS, where we have identified hypo and hyperinflammatory. They have also identified what is a class 1 cards and a class 2 card. And these are identical to the hypo and hyperinflammatory kind of processes that we have seen in other ARDS. And because they are very different, they do respond a little differently. For instance, the way in which they respond to steroids will depend not on the existence or the absence of COVID, but basically on the pattern of hyperinflammatory or hypoinflammatory, or what you might also call as your cards class 1 or your cards class 2, in terms of the response to steroids. The response to steroids with one group is definitely more than the response to steroids in the other group. So in other words, what you're seeing is what we thought was a COVID as a distinct ARDS entity is not necessarily very true. It is also a heterogeneous entity like other ARDS, and it seems to have inflammatory subphenotypes that can be very clearly identified. Another usual concern that we have is, remember, our concerns about extrapulmonary and pulmonary ARDS. The unfortunate problem with much of this has been the classification on the basis of clinical parameters has been quite difficult. But over time, we are recognizing that there's a large amount of a difference in the pathology, where in extrapulmonary ARDS, endothelial injury is far more common than the alveolar injury, which is focal and is present in pulmonary ARDS. And the kind of inflammatory pathways that they both excite are completely different. Maybe we can use this in the future for making a differentiation in terms of the etiologies of extrapulmonary and pulmonary. And maybe we can use this as a phenotypic way in which you can individualize a very specific therapy. Everybody points to this live RCT, but just for the sake of not having too much time, I'm going to say basically this was not a good study of phenotypes because they didn't do a formal cluster analysis to differentiate the groups. They just called it focal and non-focal, and they had a very serious problem with the design where they had problems with classifying the patients appropriately. So I'm not going to say that this is proof of phenotyping being of value, but this is a very interesting kind of an idea. Okay, I'll leave the live RCT for now. Let's go on to sepsis. One of the largest studies that are related to sepsis is the one by Seymour that was again in 2019, okay, where they again used prior databases on sepsis to subphenotype these patients. Here they used a little bit more complex kind of methodology. They didn't use the standard latent class analysis. They used a AI method called the optics, basically to select the variables. And if you look at the variables that they selected, they very deliberately picked variables that you and I will find as markers of the severity of sepsis. And they didn't use an AI method for looking at, non-traditional markers. So they were very clear about the fact that they want to see what we typically would see. And as was expected, they are distinctly different. Okay, I'm showing you this in terms of varying subsets. But basically what they identified was not just two phenotypes or anything. They were able to identify 4 subphenotypes of sepsis. The alpha phenotype is usually the one which is associated with the lowest amount of abnormalities or of organ dysfunction and usually has a good survival. The delta is the one which has the highest problems, mainly with hemodynamics and with lactate and transaminase levels, but it is clearly associated with a very poor outcome. And there's a distinct difference, as I said, since they go through a process of formal cluster analysis, each of these groups is distinctly different from one another. And if you look at their mortality, there is definitely a difference between the mortalities in each one of these subgroups. Okay, again, this is just showing you that the cluster analysis was very good. And when you look at them, this is the survival data. As we said, alpha is associated with the best outcome, delta is associated with the worst outcome. How about responses to specific therapy? Okay, I'll come back to that a little later. But when you look at these same subsets, and okay, when I look at it broadly, I'll say, oh, alpha, you're saying is the patients who have the minimum amount of organ dysfunction, the ones who have the greatest amount of organ dysfunction, transaminase elevation, and lactate levels are the delta. Isn't that a marker of true severity alone? And what they did was in this particular study, they said, okay, we have to show you very clearly that alpha and delta are different from our markers of severity. And they actually bullshitted a little about it. If you look at the graphs really very carefully, okay, and if you look at the alpha, which is marked here as the pink one, and the delta that is marked as the yellow one, okay, and you look at the proportions in the varying Apache subsets, okay, the highest Apache scores and the lowest Apache scores, as was expected, as the Apache score got higher, the percentages of the alpha subset went down, and as the Apache scores go higher, the percentages of the delta subset goes higher. Or in other words, in a high Apache group, you have more delta patients, and therefore it is probably because of this that their outcomes are very clearly different. And this is important because what we see over here is these subsets that they have derived are probably markers of prognosis or I mean of severity that is underlying. Okay, and as a consequence, they may not be the ideal kind of markers of phenotypic differences between the patients. We have to be very careful about this. What they showed again in a model, if they change the phenotypes, naturally the responses to therapy were very different. Here they looked at EGDT, and basically, if you look at it broadly, it is a neutral therapy. A very small number of people are hurt from the EGDT process. Okay, but what they saw is by changing the phenotypes, you probably, if you have a dominantly delta phenotype, there is likelihood that you may benefit from the EGDT kind of a process. Okay, or rather with the alpha phenotypes, with the increase in the alpha phenotypes, you have a benefit from the EGDT process. In contrast, when you have a greater amount of delta phenotypes, the harm from the EGDT process is also something that is worse. Or in other words, they were able to show that you can divide them into 4 subphenotypes that have differences in the way in which they respond. But they were unfortunately not able to demonstrate that these were distinctly different from the traditional predictors of severity, okay, nor were they able to show that there is a time invariance. You probably saw this over a period of time. Many of these patients probably would have a change in their parameters over a period of time, and as a consequence may not be true subphenotypes. So in that sense, this is a poorer study than the ARDS study, and that is effectively what we have right now in terms of phenotyping. Okay, so effectively, what are we doing with all of these phenotypes? So if I say that if I know my phenotype, I'll be able to specifically treat the patient appropriately. The question that you will always ask is, how do I derive these phenotypes? Do I require a specific higher level of knowledge for me to identify? I know that just because a patient has a higher interleukin level, that they doesn't necessarily identify them in one phenotype or another. Okay, I need to have a lot more of a complex kind of an analysis, and this is what scares most of us as common people, where basically we have very opaque data sources from these studies, and we just don't know how we can use these multiple parameters to derive our so-called phenotypes. There has been some solution. So for instance, in the ARDS studies, which have something like several 40 or so phenotypes, you can identify 3 or 4 phenotypes that have very good performance. I mean, 3 or 4 parameters that can identify these phenotypes with the greatest amount of accuracy. And this is something that we probably need to look at in the future. Okay, so what is our current level of phenotyping? We don't understand the biology of sepsis and ARDS well enough that we can't very clearly say that we can look at all these markers and be comfortable that they are good descriptors of all the differences between these groups. So we need to look at non-traditional markers, which the AI algorithms will derive, and that usually turns us off. It makes us very uncomfortable. Okay. Then the fact is, when we look at these parameters, many of them require multiple biomarkers to be assessed, which are generally not available and probably not uh, inexpensive. They are very expensive. And we have a problem about reliability in terms of what we are going to be deriving. Many of these studies, as I've shown you, are derived completely from retrospective data, and there is no proof that dividing patients into subphenotypes actually translates into dramatic outcome differences. So if I was to look at it, it'll be like whenever you get into a car with your 10-year-old kid basically sitting in the back, one of the first things that they will ask you is, are we there yet? Are we there yet? And the answer to that is definitely not. We are nowhere near that. And I think we need to go a long way in terms of understanding how we can use these phenotypes to individualize patient care. Okay. But
Yeah.
what we have learned is, I think, the idea behind cluster analysis, and that can be something that will change the way in which we look at the subgroups of patients that we're going to be dealing with. I hope there was some clarity in what I've said. Okay. But I'm pretty certain that if you listen to a recorded version of this, you're probably likely to, uh, you know, make some sense of it more than what I have already done. It looks like Venkat is already falling asleep.
No,
All
no,
right.
no. So I just listening recorded version from where, sir?
I don't know whoever has a recorded version, but I also have a recorded version of myself. If
Okay.
anybody wants to listen to it, uh, I can send a Zoom version
No,
of
no,
it.
this will be also available as a recording version. So I was actually listening from the first slide to last. I was trying to get into the information which you said in the previous talk in the journal conference in here. So right now the clustering which we are talking about from the variables which actually have a discriminating from the other group, and you used many examples for that. The overlap right now is the predictors, severity markers, scoring systems, and all. And some of them are having an overlap. And you're saying all
Yeah.
of them putting together, we may need some AI-based model to actually give the
No, no,
discrimination.
no, 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 no. I think I'm confusing you. We need to make a big differentiation between the identification of individuals on the basis of severity, like we would see with the Apache score and all of that. That is our traditional way of doing it. Okay. And as I said, it is usually an end stage kind of a marker. Okay. You can easily say somebody is going to die if they already have severe organ dysfunction, severe cytokine levels, have a lot of problems with the hemodynamic. That is a late predictor, and that has been the nature of our prediction in terms of outcomes. Okay. We have no way in which we can make these predictions much earlier, and right now, we recognize that we can't use that traditional way in which we make our predictions, that we need to look at the variables in a completely different way, in which they identify individuals as groups, okay, who may or may not have differences in their response to specific therapies. But what we are interested in is the groups that do show a response difference is what we are interested in, so that we can individualize therapy for them. To identify these groups, it is quite important that the parameters that we are using for the identification should not be linked to severity of illness. And that's what we saw in the sepsis study. The
They had some
parameters that
link.
the 4 subgroups have a
Yes,
direct correlation with the
correlation.
severity of illness parameters. So as a consequence, they are not ideal parameters. The second thing that we also need to have is, since progression over a time will change all these parameters, If there is an identifier that changes over time, it is more a marker of the severity than it is a marker of the person. And we need to be able to eliminate it from our analysis in some way. And that is where we need to get better over a period of time. We need to make these distinct differences between, the
Severity.
phenotyping processes and the variable, multivariable analysis derived processes. Okay. And it should be sufficient enough for us to, be able to make the predictions before uh, the patient progresses to a bad state. And it's also very useful for us to be able to use these subsets to individualize therapies to the individuals who are likely to respond versus those who are not likely to respond. And that's what we are showing. The initial signals seem to suggest that when you use cluster analysis methods, that there is some amount of strength in these signals developing, but there is still a huge amount of overlap in terms of
Yeah.
the severity of illness and a huge amount of overlap in terms of the time.
I was trying to point out that overlap, sir. You have
Yeah,
shown both recruitable, non-recruitable phenotypes.
yeah,
Which actually the class one, class two, which was there from 2014, and in
yeah,
Gatineau came up as COVID associated ARDS as
yeah.
kind
It
of
was
a
also
low
looking very
compliant, high
similar.
compliant kind of lungs.
Yeah,
So again, in the sepsis trial, also you have shown the parameters which have been used to actually clustering them or phenotyping them. Many of them, including lactates and many.
yeah, are markers of severity.
Uh,
Exactly.
so there
That
was
is
an
the
overlap.
no, that is the biggest criticism that we have of the current studies. Okay. In fact, the first time I ever presented this, okay, it was in that European, Indo-European, whatever conference that they had on
Yes, I see.
ventilation, ESICM kind of a thing.
Euro
And
ICM.
one of the individuals who was sitting in the audience was somebody who had co-written the paper with that the ARDS paper that I was talking about. And the first question that he asked me is, "What do you think about this association between severity of illness?" I was quite dumb. That's when I started learning or listening to all of this. And I think what we recognize right now is the way in which these phenotypes have been derived up to now are full of holes. Okay, invariably retrospective, yeah, invariably with a lot of parameters that are markers of severity. I think we cannot exclude them. So if there is somebody who starts off with a low interleukin 1 and raises it and has a different outcome from somebody who starts with a high interleukin 1 and drops it, the trajectory of those interleukins is relevant. So you have to include them somehow in the phenotyping of the patient. You can't say that all parameters that change over time should be excluded. But the way in which that analysis has to be done is a lot more complex. Okay. So, as it stands right now, we are just understanding the complexity of this analysis. We have just not come anywhere near, considering the
Uh,
use of these phenotypes for
So
subdividing our
taking
treatments.
this opportunity, if we look at now the way the malignancy oncology has been progressing,
Definitely.
in phenotyping, genotyping the malignant markers,
Yeah.
and targeting them with many
Yeah.
biologicals, and the way
Yeah.
it's changed the whole way where as we look into the oncology is phenomenal, sir. So I
Yes.
think these are the two examples which you took as ARDS and sepsis in critical care. But
Yeah.
there is a lot of progress, even though it looks very primitive in the early part of phenotyping in critical care, but in other fields, particularly in oncology, I could actually clearly
Yeah.
make a map
No,
the
they've had not just phenotyping, but they've also
phenotype.
gone on to the process of genotyping very,
True.
very clearly to make these differences, and it's dramatic. I can even talk about one of my own colleagues who had a massive non-small cell carcinoma, which was identified, sub-identified, and basically they gave him oral therapy, and he went through the entire process while he was working in the ICU and had a reasonable cure. There's no question about it. That is very different. I think we can learn a few issues from oncology, but that is a little, the time
Different
scales are
ball game.
different.
Mm.
The time scales are completely different. Okay, here we're talking about very acute time scales which are associated with major deterioration. There, you're talking about much larger scales. So even the process of getting the kind of subsets that they had is probably a little far away. I'm not trying to put this down. I'm just saying that it is a complex process. We have just not achieved the kind of success that the oncologists have
Oncologist
achieved up to
typing.
this point in time.
And genotyping, adding to this phenotyping in sepsis, and as these things are going, progressing, mapping genomics right now, and also the ethnicity, the geographic location, and the genotyping. Will that add to this phenotyping in future, sir?
There has been some. I've actually had a comment somewhere related to this. Um, yeah. See, ultimately, genotypes are relevant, but genotypes will depend on how they interact with the environment to produce your outcome. Okay. So, generally, there is a lot of overlap, and I think the predictability that we've had. There has been some studies I've looked at it where they can use 4 or 5 specific DNA markers to identify different subsets of patients. Whether it makes a difference in terms of your outcomes, say, compared to a phenotypic kind of a method, I don't know. Okay, but ultimately, that may be one other way in which you can look at it. There is a study related to that
But
also.
very interestingly, you quoted the two things which actually I think all of us clinically look at. One is when we try to recruit with a high PEEP or recruiting a lung, some of them do respond, some of them don't respond. And as you see, the most of the studies are equivocal. Because of that, maybe it negates to each other. Some get benefited, some get harmed.
Absolutely.
So which phenotype will get benefited, which phenotype will not get benefited is the million-dollar question which we are all
Yeah.
searching.
Or will we even identify it? I don't know.
No,
Okay.
yeah.
So,
But
and again, we need to do this prospectively. So far, we have derived it all from retrospective databases. They are high quality databases, no doubt. But the fact of the matter is, it's all been retrospectively derived. We need to substantiate this prospectively. So, a lot of it is still there. But like I said, many of the phenotypes that we have derived up to this point in time don't fit the category of the ideal phenotypes yet. So we need to seriously relook at a lot of these processes.
and there is
Okay.
another interesting point you said alpha phenotype to a delta phenotype, and the volume or EZDT, it's more of adding a small fixed amount of 30 ml per kilogram volume is actually detrimental in this hyperinflamed group where the markers are higher, whereas it is not the same with the alpha phenotype. As you mentioned, the volume adding has been a
I'm,
problem.
I'm kind of getting confused. The alpha and delta is in sepsis.
Yeah, sepsis group. And
Yeah.
EZDT phenomenon has been shown to be very detrimental in one group compared to the
Yeah,
other
versus the other. Yeah, it
group.
looks
The
like
EZDT is
the
nothing but
delta
a
phenotype gets worse with the
worse,
EGDT approach, then the alpha phenotype seems to show some kind of a response. Yeah.
right? And if you look at that, EZDT is nothing but a fixed amount of volume. The
Mm.
resuscitation with a fixed amount of volume, not looking at. So the maybe the less severe variant tolerates it well and get more benefited than the sicker
That may
variant.
be true. Maybe true. There's a lot of ideas that we need to look at over a period of time.
But
There's no question.
if we find out that phenotype, then probably that's again a million-dollar question where the patients can get volume or not. Again, these are
Yeah.
the clinical implications.
No, the biggest problem, as I said, again, when you look at the phenotype, if you have a single marker that will be able to identify a phenotype, that's what you're getting in oncology. Very typically, you have a single marker that identifies
Yes.
patient responses. It'll be great. Up to this point in time, we only have a cluster of markers, and we have not been able to derive simpler models. The ARDS people have shown that you can use 4 parameters to make that same kind of distinction between the P1 and P2. Okay. But still, it still involves a few parameters that you can't traditionally measure. So till it comes to a point where literally get some way in which I can identify it very rapidly, and that also is going to depend on the kind of biochemical chemical analysis and the methodology that improves over time. It may become a point at which you just feed the number into all the blood into a sample. It say, oh, P1 phenotype. Okay, so in which case you can do that, but that may be something in the future. Okay, but we need to identify this a little bit more carefully. So far we have not had the P1, P2 is not as distinct as it should be right now. Okay.
So you must have been actually clear three major controversies of this era: steroids in ARDS or sepsis, fluids in ARDS, in which category, and the last one whether I can recruit or not. So phenotype could have been answered all those three questions if you could have been a pinpoint answer for that.
Yeah.
But sir, it has been an excellent presentation of phenotype, sir. I do understand I may need to look at your slides and presentation maybe a couple of times more to understand it little deeper. But that's how it is, I think.
I
To
can promise you, I understand myself the more I talk, but that doesn't mean that I'm able to make people understand a little bit
no,
better.
I think that's where we are right now with the phenotypes, and I think we will try to learn it more with your repeated recorded videos from the same one. We will share with all the delegates, and we have a good number of delegates sticking to that to this talk, sir. And thank you very much. It's a complex, and I think it's a topic where we're still being on the process of evolving, as you said, yet to reach there. And it will be continuing for maybe a decade more yet to reach. We are not seeing any light in any tunnel. So thank you very much, sir. And
Thank you.
yeah.
I suppose we don't have too much time for any interaction with the
Yeah,
audience,
so
is it?
I think there were not many of the doubts or questions related to this. But
Everybody's mouth was a little wide open, I suppose. Sorry, release me. Are we
yeah,
there
so
yet? Is the kind of
whatever
answer.
questions were there, I tried to ask you the same way, parallelly. Whatever
Okay,
I could
fair enough.
understand also in the same way. And I
Okay,
thank all the participants for being there with Ram sir and me and be a part of this. And we continue this journey with the help of all our teachers, our seasoned speakers, sir. And I conclude the session. Thank you very much to be a part of it.
thanks, Venkat. Thanks for being patient with me and allowing me to get 3 attempts before I got my first talk. Okay,
It's a pleasure for us. Yes, we missed you once or twice, but we are here to make sure that you are here with our program. We can't miss you, sir. Thank you.
thank you. All right, bye.
Bye.